Well, good morning, everybody, and welcome to another PCF webinar. This is Declan Murphy, urologist here at Peter MacCallum Cancer Centre in Melbourne, joined as ever by my co-host, Professor Michael Hofman, nuclear medicine physician here at Peter Mac in Melbourne. Michael, good morning.
Good morning, Declan. How are you?
Good. Nice to be back on one of these ProsTIC PCF webinars, isn't it?
Outstanding.
Yeah, fantastic. So thank you to those of you who are joining us from all around the world. Michael will fill us in a little later on about exactly how many people are joining and where exactly you are in the world. But thank you very much, wherever you might be, for joining us. It's just turned 6 a.m. here in Melbourne. It's winter, it's cold. So for those of you sweltering in Europe and North America, you have our sympathies. Send us down a bit of sunshine. I think that's our message. And also joining us here in studio is a friend of the podcast, friend of the webinar, Dr. James Buteau, who's a nuclear medicine fellow here at Peter Mac. James, welcome.
Hey, thank you. Heart of the winter in Australia.
It is.
Freezing.
Well, you're Canadian. You're used to this sort of stuff. And
surprisingly, it's colder than Canada.
Is that right?
Feels like it, yeah.
So tell us a little bit about the merch you're wearing. I can't help miss
some GU cast toque or a beanie for Australians. It's very, very warm.
Is it? A toque?
Yes. A toque. I mean, it's probably more French-Canadian, but hard not to say toque.
Instead of beanie. It's a beanie to the rest of us, I think.
Yeah.
Toque sounds a bit more elegant, Michael, doesn't it?
Toque.
It does.
Yeah.
What is toque? And yes, so this webinar will, of course, be posted for later. It'll be on YouTube, and it'll be cross-posted as a podcast on our podcast, GUcast, which myself and my colleague, Dr. Renew Eapen, post. And that's a shameless plug for our podcast because it's great fun. If you want to join us on our podcast, GUcast, you can find us on Spotify, Apple, or YouTube, wherever you might listen to your podcasts or watch your podcasts. Anyway, that's enough shameless promotion. Michael, let's hand over to you and get the ball rolling.
Well, welcome everyone. We have a webinar titled New Era of Lutetium PSMA Post-Approval, Perspectives, Challenges and Future. And we have a star-studded panel that we'll probably introduce as we go along the way. Just a few statistics for the meeting. Firstly, you can ask questions. Now, don't use the chat, use the Q&A feature. You'll see at the bottom of your Zoom webinar both Q&A and chat, and please post your questions in the Q&A session. Then people can upvote them, and we will start with the highest voted questions and answer them first. Also, if you want to ask your question live, get your camera and microphone ready. We can elevate you to the panel, and you can then participate in a bit of banter with your Q&A as well. So do get your camera microphone ready. We had an extraordinary, this was last night, and I think it was up to 740 registrants this morning, but from 58 countries, which was really quite remarkable, and some standout, unusual countries. South Africa, really good, strong nuclear medicine in South Africa. Obviously, most of our attendees from USA and Australia, but really such an amazing mix. We're imaging people, so James had to make a graph of it. It wasn't good enough just to have a table. And here is where our specialists are from. And you can see we mainly have nuclear medicine specialists, but there is a good mixture, a lot of industry representatives, urologists, medical oncologists, radiation oncologists, and patients and consumer representatives, and many of them online as well. Please don't ask your personal medical questions. We can't give you medical advice on our podcast today. And with that, we might hand over to...
Michael, before you do, isn't it interesting? There are more urologists than medical oncologists on this theranostics webinar today, as it happens.
That's an astute observation, Declan. And as I was looking at that, I'll also make the observation that from many of our smaller countries, places like Peru and African countries and some of the representatives where there's only one or two from a country, it was often a urologist. So it seems that maybe urologists are being the medical oncologists and the nuclear medicine physicians in some of these places.
I love it, but we do have a few eminent medical oncologists to defend the realm, because I wonder whether they've surrendered it to nuclear medicine physicians, actually, this whole theranostics. I'm sorry, and we're not going to do that. But I'm being provocative, Silke and Louise, but it's great to have...
No, I'm already saying no to that.
That's Professor Gillessen can't restrain herself. But, I think it's a very big multidisciplinary group and lots of industry interested as well, which we love because we need industry to support the ongoing research in PSMA theranostics. But yes, Michael, shall we invite some of our panelists?
We might invite Dr. Howard Soule, who's the Chief Scientific Officer of the Prostate Cancer Foundation, to say a few words. Over to you, Howard.
Thank you, Michael. Thank you, Declan, and welcome world. that has joined our, I guess this is the third now, ProsTIC PCF seminar. The Prostate Cancer Foundation is the world's largest source of philanthropic funding for prostate cancer research. We're focused on new treatments, better treatments, and better outcomes for patients everywhere in the world. Just by way of background, in PSMA research, my colleague and I, Dr. Miyahira, penned a review article for the Journal of Nuclear Medicine. Gosh, how many months ago now, Andrea? Probably 6-8 months ago. That not only traces the history all the way from the cloning of the molecule, all the way to the approval of radioligand therapy by Novartis, but also shows exactly where our foundation inserted our funding priorities into this topic area. And it's substantial and it goes way back. So we're very proud to be an enduring supporter of the Peter Mac program, which Dr. Hofman and colleagues named the ProsTIC program. It's going quite well. I should say, though, we also fund a lot of other radioligand therapy research all over the world, including UCLA, Weill Cornell, Sloan Kettering, and the list goes on and on. So I invite all of you to come to our website, www.pcf.org, if you want to learn more about us and our various research funding programs. And it's a real pleasure to be here today. Andrea, would you like to say a few words?
Sure. Thank you, Howard. My name is Andrea Miyahira. Hi, everyone. It's really wonderful to see Michael's global attendee statistics. So I'm the Director of Global Research and Scientific Communications at PCF. I work closely with Howard. And I want to thank Michael, Declan, and the team for organizing this webinar. Now that lutetium PSMA has been FDA approved, I think today's discussion on the challenges and next steps is well timed and extremely relevant to the community of attendees joining us today. So thank you. I'm looking forward to this.
Thanks, Andrea. So I'll switch over to my slides. So, this is a little bit of a curve, and all new technologies really go through this cycle. You get a technology trigger. There's a lot of hype. You get a peak of inflated expectations, and then it drops. And doing PSMA theranostics from early on, I think we've sort of seen this take hold. Very early on, we saw some great data coming out of Bad Burka from Richard Baum using PSMA INT, showing some pretty impressive waterfall plots of responses in patients who had failed other therapies. And then even a little bit earlier, data using MIP-1095, which was a small molecule labeled to iodine, I-124 for PET imaging and I-131 for therapy. This is data out of University of Heidelberg in Germany, but a close collaboration with US colleagues. And these sorts of images around actually 2012 for us, maybe as early as the European Association of Nuclear Medicine meeting in 2010 was when I first saw some PSMA pictures, really struck our interest. And then in 2015, this quite extraordinary image of PSMA 617, a complete response after 2 cycles of treatment, run the Society of Nuclear Medicine Image of the Year. And the S&M Image of the Year always captures everyone's attention, and people get invested in this new technology. We started a prospective trial in the same year, 2015, published in 2018, and produced this illustration, won the Image of the Year award in 2018. And certainly these images generated a lot of hype across the GU medical oncology community and also amongst patients. And as Howard alluded to, Andrea has published this manuscript in Journal of Nuclear Medicine, which goes through the history of PSMA. And this is the last decade. I won't go through it in any detail, but the manuscript actually starts a decade earlier when the PSMA was cloned, I think in Memorial Sloan Kettering and Weill Cornell, lots of rich research. John Hopkins heavily involved. So we've come into the piece a bit later, but around a decade ago now, and it's been a really fun journey. Our group in Australia, through the ANZUP Cancer Trials Group, went on to do the therapy trial, the first randomized controlled trial of lutetium PSMA. And we chose a fairly good control arm, being carbazitaxel, a very active therapy, results published in The Lancet last year. And we met our primary and key secondary endpoints. PSA reduction over 50%, 66% with lutetium PSMA 617, compared to only 37% with carbazitaxel. So a very large difference between the primary endpoint being a biochemical response, but it wasn't just the biochemical response. We also had differences in radiographic progression-free survival, RECIST responses, and importantly, less side effects. Last year, we also saw the results of the phase 3 VISION trial. This trial was started by Endocyte, subsequently taken over by AAA Novartis, a phase 3 registration study showing us what we wanted to know, which was survival. Does it improve survival? And indeed, this study showed definitively an improvement in overall survival, median of 15 months compared to 11 months. Perhaps that difference not as large as some of the very early hype from 10 years prior, where we saw these really spectacular images, but nevertheless a significant improvement in survival. And what I've learned as a nuclear medicine physician is how to interpret these Kaplan-Meier survival curves, because they do show a median, and the median can hide some of these extreme responders. And we do see, I think, a sort of 10 to 15, maybe 20% of patients who do really, really well with lutetium PSMA 617. But I do wonder if they're not captured on these median survival curves. You kind of have to shift the whole curve over to improve these medians. So sometimes Kaplan-Meier survival curves kind of underestimate what we see as clinicians. But not only improvement in quality of life, survival is important. We need to improve quality of life as well. I think sometimes in oncology we improve survival with a treatment, but because of the side effects, you can feel significantly worse. But with lutetium PSMA 617, there's no doubt that we have a massive improvement in quality of life, very nicely captured in this data presented by Karim Fazazi at ESMO last year from the VISION trial. This is the time to a worsening of the brief pain index, a patient-reported outcome where patients are reporting their pain experience on forms. And you can see the time difference, 14.3 months compared to 2.9 months. So really over a year difference in this time to pain deterioration. And this is what we see clinically with this therapy, much like external beam radiation. When patients have focal pain, let's say in the hip, and you irradiate the hip and the pain improves. When you've got pain all over the body, you can't give external beam. But radiation as a treatment modality is very effective for pain relief. And, you know, this is not a drug. You can think of lutetium PSMA 617. I think of it more as a radiation delivery device. In fact, we inject it intravenously. It travels around the body, binds to prostate cancer cells, is taken up into the tumours and irradiates them with beta irradiation. Not too dissimilar than the effect that occurs with external beam radiation, but with a 1 millimetre path length and a really targeted fashion. So very, very good for pain control. At ASCO, only a few weeks ago, there were 3 presentations out of the 5 in the oral prostate cancer session that related to PSMA theranostics, which I think tells us the global interest in this area, which is mirrored by the number of registrants from various different countries that we have on this webinar. And we had the pleasure of presenting the 3-year follow-up of the therapy trial. So we now have mature data. And one of our endpoints was the overall survival. And in fact, we did not show an improvement in overall survival compared to carbazitaxel. You can see the hazard ratio there of 0.96, restricted mean survival times of 19.1 and 19.6 months. So no difference in the arms. Why is this? Well, one, the study was not powered for overall survival. This was only a 200-patient study. Also, there was a lot of withdrawals in the carbazitaxel arm post-randomization. As an open-label trial, patients knew which arm they were randomized to, and 15% of patients randomized to carbazitaxel said, no, I don't want chemotherapy, and they withdrew, and they sought mainly off-trial access to lutetium, which was available at the time in Australia. And in our intention to treat analysis, we analyse as per the randomised arm. So if you're randomised to carbazitaxel and you receive lutetium, you'll still come in the survival statistics for carbazitaxel. And also post-protocol, so after you had carbazitaxel, lutetium was fairly widely available in Australia, and around 20% of patients accessed lutetium after carbazitaxel. So this was more an assessment of the addition of lutetium to the treatment armamentarium. And you see those RMSTs of around 19.5 months. They're still pretty impressive. If you compare it to the TROPIC trial for carbazitaxel, it's around 4 months longer. So I think what we're seeing in the therapy trial is the value of the addition of lutetium, not necessarily a replacement, because you may have both carbazitaxel and then lutetium, or vice versa, lutetium and then carbazitaxel now in your treatment journey. And that's largely what we were assessing. Nevertheless, when we look at this hype curve, perhaps the trough of disillusionment happened when we don't show an improvement in overall survival. But now we are coming to our slope of enlightenment as it's FDA approved and as this treatment is implemented globally. And similar to the VISION trial, we do show significant improvements in overall in quality of life with lutetium PSMA. On the left is deterioration-free survival. This is a statistic I like because it's very patient-centered. It's the time to a 10-point deterioration in your global health status as reported by patients using the EORTC quality of life parameter, progression, death, or treatment discontinuation. And you can see that there's a significant separation favouring lutetium PSMA that persists really right from the get-go onto 12 months and beyond. And in terms of patient-reported outcomes, it's really the side effects that occur with chemotherapy, such as skin rash, neuropathy, hair loss, altered taste, diarrhea, that simply don't occur with lutetium PSMA 617. And this results in really vastly superior patient-reported outcomes in many, many domains. In the therapy trial, we measured, I think, 58 symptoms, and the trend in each symptom favoured lutetium. And in many of them, as listed, there was a large difference between the two treatment modalities. So our conclusion from the therapy trial, to summarise it, is that it supports the choice of lutetium PSMA 617 over carbazitaxel for patients with PSMA-positive disease on the basis of improved efficacy, improved quality of life, and less adverse effects. That's despite not showing an improvement in survival compared to carbazitaxel. We now are entering the era of really tweaking this therapy. How can we improve these statistics? 19.5 months survival is not good enough for our patients, so we want to do better. And in the rest of the talk, we're going to hear a little bit about the implementation of PSMA and how we can do better. Before I end, I just want to highlight some of our imaging prognostic biomarker work, because I think this is key to lutetium PSMA. We need to think of it as a device that delivers radiation. And if we're not delivering high doses of radiation to sites of tumours, then we don't get good responses. And we can do pretty well with our imaging in predicting how much, because a PSMA PET scan is essentially the same radionuclide as we're using in the therapy. Therefore, we can visualize the biodistribution. And what we've done here is contoured the tumours using our MIM software, which is our favourite software for reviewing these PET scans and doing some of these advanced quantitations. And then we can find out the mean SUV, which is the mean intensity of uptake at all sites of tumour. And we do this as a clinical routine now. But at many sites in the world, this is not able to be done yet. So there's work to be done in your community radiology centre. You're not going to get some of these advanced quantitative measures. But using some predefined thresholds, and this was embedded in the therapy trial, 30% of patients had an SUV mean over 10, which we defined as very high PSMA expression. And what we saw is that your odds of responding to lutetium versus carbazitaxel was higher in the whole cohort of patients because everyone was pre-selected for high PSMA expression. But if you were in the very high group, you had a 12 times likelihood of responding to lutetium compared to carbazitaxel, compared to a 2 times likelihood in the group with lower PSMA expression. That's a large difference, and it identifies PSMA PET uptake as a predictive biomarker for response to lutetium versus carbazitaxel. And if you're in this very high group, you really want to access lutetium PSMA therapy. Perhaps it's a little bit like some of the markers for immunotherapy, where you can look at your high mutational burden. And if you happen to have some of these features, then you really want to access your immunotherapy because your chance of responding is very high. And I think we have this biomarker with lutetium PSMA. Also at ASCO, Andrew Armstrong from Duke, together with Philip Kuo, presented the imaging biomarker data from the VISION trial. And this is the overall survival data. And you can see, similarly, they found an SUV mean of 10 or higher for that highest quartile. And the median overall survival was 21 months compared to 14.5 months in the lower quartile. And you can see a significant separation between the highest quartile and the other 3 quartiles in this data. So really, we are using this as in our clinical practice now, and we'd like to see this globally adopted. In Australia, we have more than 10 clinician-led trials of PSMA theranostics underway, funded through PCF and other mechanisms, the Prostate Cancer Foundation of Australia, Movember, and many run through our ANZUP Cooperative Trials Group as well. And this is mirrored globally. This is a slide thanks to Declan that he got, I think, from Novartis, showing the global landscape of clinical trials across first line, second line, third line, bringing it all the way back to a first line treatment. And you can see here monotherapy, in green combination therapies, and in the pink color comparing to randomized data comparing to a standard of care. Here's different radionuclides: lutetium, iodine, thorium, actinium. So we have a variety of different radionuclides currently being studied, and whether these trials are phase 1, phase 1/2, or phase 3. So lots of interesting data currently underway. And the next 1 to 5 years, we're just going to have so much data being presented. And with that, I'm going to pause and hand over to Professor Ken Herrmann. Ken directs the Department of Nuclear Medicine out in Essen in Germany, and is a real key opinion leader globally in nuclear medicine and molecular imaging, and a good friend of the podcast, GUcast, and our webinar. And Ken's going to tell us really about the implementation of PSMA theranostics and how we're going to adopt this technology and some of the challenges globally. So I'll hand over to you, Ken. Give me a second while I get your slides up. They'll come in about 20 seconds time.
Thank you very much, Michael. And first of all, a huge compliment to the organizers here, both the PCF, but also the ProsTIC team here at Peter Mac. I'm very happy and grateful with this expert panel to talk a little bit about tackling the last mile. And while Michael is finding the slides, we can already go to the second slide, and I will discuss a little bit what I mean. Why do I even want to discuss tackling the last mile? We know that the recent PSMA is approved since March 2022 in the US. We expect the EMA approval in end of 2022. And this also will most likely go along with the increased demand of PSMA ligand therapy. And there are a couple of major challenges which can be expected post-approval. One of them is that we need to be sure that we have enough theranostics centers. And this means not only the infrastructure, but we also need the personnel. A very important part is also to tackle the patient flow, to make sure that the patients who are qualified for PSMA ligand therapy get access to it. And of course, reimbursement. Reimbursement, and this does not only mean the reimbursement of the compound, but also of the procedures. And all this together is, for me, the summary of tackling the last mile. And as Michael already shows, that this is actually a term which I stole from the logistics industry. And Michael showed before the Gartner hype cycle is one of the classics of every MBA. Another very classic of MBA school is actually the entry, departure, and re-entry of DHL, which is a logistics company into the US market. So in 2008, on the left side, you can see, and it's big headlines, DHL, a logistics company, ended the US parcel service after 5 years and wasting more than $10 billion US. And the reason was not that they were not able to actually deliver and distribute the parcels all over the world, but the problem was really to get it from the latest hub to the house, so really the last mile. Then on the right side, you can see 10 years later, in 2018, finally, DHL announced to come back. This is one of the announcements in Wall Street Journal. Another one really said, DHL is getting back into the parcel last mile delivery, but now with a twist. And then you will see 5 years later, and this is really just a few weeks ago, there's a huge headline saying all of a sudden, a study showing that DHL reveals how the logistics strategies for the last mile can be optimized. So looking at the need of theranostics centers, and this is now, as you know, I'm German, I'm from Germany, and we have a little bit of a head start regarding theranostics. We have 20 years of experience with Priotate. We already have 7 or 8 years of experience with PSMA ligand therapy. And we have 83 million inhabitants, and there are a total of 35-40 theranostics expected to meet the demand, high volume centers to meet the demand, which we expect after the approval of PSMA ligand therapy. If you translate this to the US, with 320 million inhabitants, we expect around potentially, if we extrapolate the numbers, to 140 to 160 theranostics centers. And there's actually a recent editorial in the Journal of Nuclear Medicine from Johannes Chern and Jeremy Calais, where they calculated the number of sites needed in the US if we expect 150 cycles of radioligand therapy to be delivered per year. And the calculation is very simple. You can see if 2 cycles per site per day are delivered, around 280 centers are needed. If up to 8 cycles per site per day are delivered, it brings down to only 70. And then if you see in the middle, if 4 cycles, this is exactly the number, 140 centers, which we would expect extrapolating the German numbers to the US. Now, what is really needed to tackle successful last mile? And it's education, education, education. This includes our nuclear medicine physician and the partners who are applying radioligand therapy. It also includes referring physicians. And of course, we have to educate patients. It's also important to invest into the infrastructure. We need to raise the awareness, and this includes not only reimbursement bodies, but also regulators and also political agencies. We need to expand the field of radioligand therapy beyond prostate, and we have to oncologize nuclear medicine. And in this slide here, you can very nicely see that there are a couple of very helpful initiatives. It's just a selection. I try to be inclusive. I apologize to major important initiatives which I forgot to include. But one of them includes, and I want to highlight this, the Health Policy Partnership. It's something which tries to establish a framework for radioligand therapy in Europe, in the US, and also in every other country and continent. A second very important activity is SNMI, which tries to actually certify therapy centers of excellence. Then, of course, as I mentioned before, education. Here, I want to quickly highlight the joint ESMO-ENM initiative, where we have advanced theranostic courses. There are certain guidelines here, for example, as a representative, a joint ENM, SNMI, and IAA guideline published both in the JMN but also in the European Journal, trying to provide a framework on how to set up a theranostic center. And of course, very important, the PCF and also the ProsTIC network here with the webinars, making sure that a lot of people are adequately educated. And in summary, and this is my last slide, if we want to make the theranostics a durable success, this really depends on successfully tackling the last mile, including the need to educate, that we have, and educating again, in this case, means not only educating nuclear medicine physicians, but also patients and regulatory bodies. We need to secure investment into people plus infrastructure. We have to work together within and beyond nuclear medicine. We have to establish financial sustainability, which is really important because there's also the term of financial toxicity getting more and more associated. And we need to oncologize nuclear medicine. As you can see on the right side, in Essen, my home department, we really believe in the future of theranostics, and we really hope that jointly we are successfully going to tackle the last mile. Thank you very much.
Thanks so much, Ken. That was a really great overview. And this is a challenge we have in every country, and every country is tackling this a little bit different. In Australia, we're working very closely with our Nuclear Medicine Society to establish a theranostics training program. We have a teaching course in about 6 weeks' time, and we've got people from all around Australia coming to that. And we want to make sure that people delivering this therapy have experience. You don't want to be delivering your first therapy and not have any training in it. This enabled poor patient selection and bad outcomes for our patients. I might hand over to Ken, who's going to introduce Silke and the APCCC meeting, and I'll get her slides up as you do that, Declan.
Thanks very much. Thank you, Ken. And please keep your questions rolling in. We're really enjoying having getting around to those later on in the webinar, so please keep your questions coming in. Yeah, so it's a great pleasure to welcome Professor Silke Gillessen, a friend of the webinar, friend of the podcast. Silke is a medical oncologist at the Oncology Institute of Southern Switzerland, and of course she's very well known for being the founder and chairperson of the APCCC, the Advanced Prostate Cancer Consensus Conference, which is my favorite prostate cancer meeting in the world. I think I'm very much on record saying it, just the most amazing meeting that runs usually every 2 years or so, and recently happened in Lugano, beautiful Lugano, where Silke is based. This is a very special meeting where the world's leading experts in prostate cancer come and do some short didactic talks, but also there's a panel vote on some of the more contentious issues, some of these challenges we have, especially with new therapies like theranostics, where we don't have extensive experience, we don't have enough to change guidelines, for example, and this panel comes together and gives expert opinion on that. So Silke is going to chat to us a little bit about the more recent messages from the APCCC panel. Silke, welcome and thank you for joining us.
Thank you very much, Declan. Thank you very much, Michael. And of course, both of you are also panelists, like is also Ken. So I guess we are all a big family. And again, I'm going to speak about the APCC experts' perspective. So this is not my perspective. That's actually what we have voted in the last two conferences. These are my conflicts of interest. And just to show you, so this is the panel. So we have more than hundreds of experts who are the experts who voting. They're all experts in prostate cancer, from urology, radiotherapy, clinical oncologists, medical oncologists, radiologists, nuclear medicine person. So you see here, they come also from all over the world. So it's quite an international voting. Maybe to say as well that we always say that just think that you have everything available, and obviously that's an ideal world, but if you could do everything for management of prostate cancer, what would you choose? And as Declan has already said, I mean, he's a very good person to make PR for our conference. APCC is really a very clinical conference, and it's all about management in situations where we actually don't have high-level evidence. And I think so this is the kind of questions we asked, and we had in 2021, that was in October, a whole chapter only about PSMA in diagnostics and in treatment, because it's such an important issue as we have just discussed. So I start with telling you a bit about the voting in which indication the experts would give lutetium PSMA. And you see here the question, it's a long one. So chemotherapy fit patients with PSMA imaging positive mCRPC, who also meet all relevant criteria for lutetium PSMA therapy and have received at least one line of AR pathway inhibitor and one line of taxane-based chemotherapy. What is your preferred treatment option for the majority of patients? And again, that was assuming all treatments are readily available and there is no molecular alteration with approved therapy. And you see here, 77% would go for lutetium in that indication. So probably all based a bit on the therapy trial. Cabazitaxel would only be given by 13% and radium by 10%. And just to let you know, the definition we made for the consensus is more than 75%. So this was already a consensus. And you can read all that. It was just published some weeks ago in European Urology. So now we have the same kind of patients, chemotherapy fit, mCRPC. They had one line of AR pathway inhibitor, but no chemotherapy. And here you see, and I think that's quite interesting, that really a clear consensus for giving these patients docetaxel and not lutetium PSMA. So 85% would go for docetaxel if someone is chemotherapy fit and had not had chemotherapy, but only one line of AR pathway inhibitor.
And I think
next one.
Sorry, Michael.
This is a key message with the hype curve, is that when people see those image of the air or spectacular responses, they want lutetium, and sometimes patients want it first line, but the evidence is not there. And the key opinion leaders recommend chemotherapy first. And even in a large centre like ours, where we give 20 cycles of lutetium PSMA per week, we direct our patients to chemotherapy first. But there are some patients who aren't fit for chemotherapy, and this is where we don't have it evidence-based. So back to you, Silke. What do we do with those patients?
Exactly. And when you say chemotherapy, it's really docetaxel, so first line taxane, because we saw before giving the second line taxane, all I mean, the consensus was to give lutetium. And again, yes, exactly what you said. So there are also, we see a lot of chemotherapy unfit patients, even if we could discuss what exactly that means. So that is quite, let's say, an individual decision until now. And here we have the question, if someone had one line of AR pathway inhibitor in MCRPC, but is chemotherapy unfit, would you give lutetium? And you can see what the panel voted, if Michael shows you exactly. So again, a consensus that 80% of the panelists would give lutetium to these patients. And I think that's a quite interesting question because also, as Michael has said, you know, like you see all these pictures and patients are really interested in lutetium PSMA. And one of the questions was, is it appropriate to recommend lutetium PSMA therapy in patients with hormone-sensitive disease outside of clinical trial? And you see the panelists very clear, 86% said no. If you go to the next one, this one was one of the questions that is not published yet. So this was one of the questions we had 3 months ago, because that's a question that comes up quite often. And I'm really interested to hear what Ken and Michael, what you're thinking. Should you give radium or should you give lutetium first, or what would you do? So in the majority of patients with symptomatic MCRPC, meeting criteria for both treatments, radium-223 and lutetium PSMA, you see here that only 20% would go for radium and a consensus to give lutetium. Even obviously, we don't have a study that shows us the comparison radium versus lutetium in these patients. Maybe if you go to the next one, I don't know, Ken, do you want to maybe, if you want go one back, do you want to comment on that one?
It's an excellent question. It's a very difficult question. Like you said, we do have data showing that lutetium PSMA can be safely administered after radium. This has been two papers which have been recently published. Talking about what's happening once lutetium PSMA is approved in Europe, I expect exactly a very similar distribution as in your panel, expert panel. Even so we don't have data, we have the feeling that if there are additional metastases, for example, in lymph nodes or somewhere else where we don't see them, we would also kind of get them with lutetium PSMA, and whereas we won't get them with radium. But overall, you're absolutely right, there is no hard data.
Maybe Michael, to be honest, this is a real question for me. So what is the price in Australia, radium versus lutetium? Is one of them much cheaper, or?
Actually, neither are reimbursed in Australia. So radium-223 was never, it's approved but not reimbursed in Australia. It's a strange outlier. So radium-223 is not very much used in Australia for this purpose. So I think you'll find almost no use of radium at the moment, but quite extensive use of lutetium PSMA, which is also not reimbursed in Australia, although, you know, it is available at our centre at Peter Mac for free. We don't charge patients for it. We are a public hospital, but we're lucky to have, you know, lots of grant funding. Essentially, the Prostate Cancer Foundation Centre of Excellence, which I should say is, you know, funded from Stein Erik Hagen out in Norway, who has given a large donation to the Prostate Cancer Foundation, has flowed onto us. It enables us to have that infrastructure to do that, but most centres simply don't have that. So we're not representative from a funding model of what's happening elsewhere in Australia, where patients are having to pay per cycle, and the cost is somewhere between $6,000 to $12,000, but that's also with PSMA INT ligand rather than the PSMA 617 ligand, which is the one we're using here at Peter Mac.
Okay, maybe that would be interesting to see in all the other countries. So in summary, I think we discussed that in chemotherapy fit patients, MCRPC, lutetium, like our panelists think, has to be given after RP and docetaxel. In chemotherapy unfit patients after an RP alone. And if criteria fulfilled, there was clear consensus for using lutetium over radium. I think quite interesting. and as you said, not for hormone-sensitive patients. And then the next big question is how to select patients for lutetium PSMA. We heard something about the SUF mean, but in a lot of reports, at least in Europe, this is actually really not given. And one of the questions was, based on PSMA PET, what threshold of uptake do you recommend for lutetium therapy? And you see here that it's not a consensus, but almost a consensus. And that was also one of the fresh questions from 2022, would go according to the vision criteria. So at least one metastatic lesion with PSMA uptake more than liver. And less would go for the therapy definition. If you go to the next one, in the workup for lutetium therapy, how do you identify PSMA negative sites of disease in the majority of patients? I think that's quite interesting as well. And if you show the results, so like in the therapy trials, so PSMA PET-CT plus an FDG PET-CT, to be honest, this is not much done, for example, in Switzerland, where I'm living and working, obviously. So that was 30% of panelists would do it like that. And the majority of panelists would go for PSMA PET-CT with contrast-enhanced CT, like in the vision study. But we have just discussed that a lot in a lot of nuclear medicine departments. There is no contrast given for the PSMA PET-CT. I think we should discuss that afterwards as well. And some panelists also said, okay, use FDG PET, but selectively if the correlation between contrast-enhanced CT provides unclear results. And then there were very few panelists who said you don't even need to identify PSMA negative lesions. And I guess maybe, Michael, if you could go back and maybe comment on these last two pies, I guess that would be interesting for the audience.
So I think really almost half the group here are using FDG either routinely or selectively, and half are using contrast-enhanced CT. Look, I think both are fine. Prostate cancer likes spreading to the bones, and unfortunately on CT you simply do not see some of these PSMA negative metastases within bone. And we certainly see patients in the clinic who say, look, I've got hip pain and it's on the right side, and I look at the PSMA PET and there's nothing there. And if you look at the CT, you don't see anything either. But then I look at the FDG and I do see an osseous metastasis accounting for the patient's pain. If you did an MRI, you would see it as well. So there are these bone metastases that are invisible on CT that are not that uncommon, and that's the strength of FDG PET. So I think it is optimal. Sometimes I hear, look, FDG PET simply too expensive, but I don't buy that because the cost of the treatment is about 10 times the cost of a scan per one cycle. So after you've given 6 cycles of lutetium PSMA, it's like 100 PET scans. So if you can select patients that are not suitable for treatment early on, you can save a lot of money. But more importantly, you can tweak the patient's management. Sometimes you're continuing lutetium, but you may be giving external beam radiation to a site of PSMA negative disease, improving patient symptoms. So I think there's a little bit of an art to medicine, and FDG, it's a bit like clinical examination. If you don't examine your patients, then you miss things and you manage patients inappropriately or perhaps suboptimally. And it's the same with FDG. When you know the true extent of disease, you can look at the patient and make the best decision for the patients in front of you. At least that's my opinion.
But would you agree? I mean, I think that's something, maybe an important message. Would you agree that if you don't do an FDG PET because you can't for some reason, but you do only a PSMA PET-CT, that you should do, obviously, if possible, from clearance and all the other things, with contrast media?
Look, I would agree with that, with a proviso that actually the contrast doesn't add a lot, because you can see the lymph nodes quite well on a non-contrast enhanced CT. So what the contrast helps is mainly in the liver, and even large liver metastases you'll see on non-contrast CT, but the small liver metastases you will miss without contrast, and they're really important because they're frequently PSMA negative. So look closely at the liver, and certainly if contrast CT is available, then use that, because you do get better quality pictures, and again, it's like a better quality clinical examination.
Great. So you now can finally go to the next slide. Thank you. So that was another question. So is it safe to recommend initiating treatment with lutetium PSMA in a patient who has a relevant impaired bone marrow function? And we defined that to be less than what was inclusion criteria in the VISION trial. So a hemoglobin less than 9, neutrophils less than 1.5, or platelets less than 100. And I think that was quite interesting. So the panelists, 85% of the panelists found it not safe to give lutetium PSMA in such a patient. So Michael or Ken, you have a lot of experience.
Ken, do you want to tackle this one?
So it's a very good question. The point here is it really depends for us a little bit also on how the distribution of the metastasis is. So if the bone marrow function is decreased because there's a lot of metastasis in the bones, we would probably still consider treating him and potentially give the patient some infusion before. If this is explained by other reasons, then we probably would still consider treating him, but with a reduced activity. But Michael, how do you guys do it?
Yeah, look, I think we might see a shift in this over time, the answer to this question, with experience. When you've got the patient in front of you with severe bone pain who has no other treatment options, and perhaps hemoglobin less than 9 where you can just give a transfusion, I think we would treat. Platelets less than 100 to start with. Actually, at the moment, we would probably avoid treating, but in some exceptional circumstances, we may consider it for symptomatic relief if we truly believe that it's going to improve the patient's symptoms. So I think it's an individual assessment, and you need experience. Perhaps when you start implementation of lutetium PSMA, this is quite a safe guideline, perhaps not to do this because you can run into problems. And it is a radioactive treatment, and one of the problems is if the patient dies a few days after lutetium PSMA therapy, you have a radioactive patient, and that causes problems in some countries. There's case reports of cremations where cremation staff are exposed to significant doses of radiation. So there are some unusual aspects of this treatment that we need to consider.
Michael, but do you sometimes reduce activity, or do you say because we know
so
that
we would
the higher the activity?
Yeah, we would dose reduce by 20% if these blood functions are abnormal, but we'd also consider what other treatment options are available. And if carbazitaxel hasn't been used as an example, in patients with a evolving leukoerythroblastic picture where there's marrow infiltration, we actually have a preference for institution of chemotherapy if the patient's suitable rather than lutetium.
Interesting. Thanks. So same thing, we see also a lot of patients with a creatinine clearance that is not normal. So the question was, is it safe to recommend treatment with lutetium PSMA in a patient with impaired renal function? And we defined that as a GFR of 30 to 49 because the VISION inclusion criteria was 50 ml per minute. So, and you see here, so 30% thought, yes, that's safe. A bit more than half would give it, but with a reduced dose, and 20% would not give lutetium in such a patient. Again, Ken, Michael, the ones with the experience.
So we would probably be a 1. Again, it depends on patient per patient, right? And it depends on how the GFR so what is the reason for the reduced GFR? But we also have seen patients already actually showing an improved GFR after treatment. So again, case per case decision, but we would probably really consider this, especially if there is no real alternative for treatment.
And we're totally aligned with Ken. We would be a 1 on this. But this is an area where you do need experience, and this is an area where we'll also do some dosimetry. We've treated a patient with an eGFR of 18 that we were concerned, and we did dosimetry after the first cycle and could show objectively that the dose to the kidney was only 2.5 gray, no different to any other patient. That enabled us with confidence to proceed with cycle 2, 3, 4, and we saw the patient's GFR progressively improve over therapy because that was resulting in obstruction of the kidneys. But you can see these APCCC questions are really relevant. They're highlighting areas of clinical uncertainty where the VISION trial or the therapy trial doesn't inform clinical practice because the clinical trial guidelines are really narrow. They simply do not include these patients. So this is the wonderful thing about the conference and these consensus questions. It fills in all these gaps that the clinical trials don't help us with. So Silke actually has about another 20 questions to go through, but in the interests of time, we're going to move on to our next talk and come back to questions. But do look at the publications that result in European urology from the Advanced Prostate Cancer Consensus meeting because they go through all of this with some discussion. So it's my pleasure to hand over to Louise Kostos. Louise will be our last speaker, and then we'll spend the last half an hour tackling Q&A from you, the audience. Louise is a medical oncologist at the Peter MacCallum Cancer Centre and our PhD fellow in our ProsTIC program, supervised by myself and also Associate Professor Arun Azad. And I'd like to say a rising star in the medical oncology world, and has been busy writing some of our phase 1-2 protocols from our care of our grant funding from the Prostate Cancer Foundation. So over to you, Louise. It's going to take me about 20 seconds to get your slides up, but fire away.
No worries. Thanks very much, Michael, for the very generous introduction, and welcome everyone. It's an absolute pleasure to be here. I'm going to be talking about some of our PSMA-based radioligand therapy trials that are up and coming at Peter Mac, and I'll also briefly run through some of the trials that we already have open. As we've already heard very nicely from Michael, Silke and Ken, lutetium PSMA is clearly a game changer and is here to stay. But the reason we do have such an active PSMA theranostics trials team here at Peter Mac is that we recognise there are some limitations to this treatment. And in particular, what we're seeing is that for many of our patients, durability of response is an issue. And many patients, despite initially responding to lutetium PSMA, they are progressing either on treatment or quite soon after the treatment's completed. And for a small proportion of patients who have a baseline PSMA and FDG PET scan that looks suitable for treatment, some of those patients don't respond at all. So this tells us that there's intrinsic as well as acquired mechanisms of resistance at play. And this really is what our trial strategy at Peter Mac is focusing on. So we're really trying to identify these mechanisms of resistance to lutetium PSMA and try to overcome them. As you can see, the bulk of our trials are combination strategies. We do also have a novel radioligand trial. And with the current flavour in prostate cancer management, looking at intensifying treatment earlier on, we do have a number of trials integrating lutetium PSMA earlier on in the treatment paradigm. So the first trial I'm very excited to talk about is the LUCAB trial, and we've consented the first 2 patients to this study this week, so they'll start treatment next week. And this is a phase 1/2 study looking at the combination of cabazitaxel, so chemotherapy, with lutetium PSMA 617. And the rationale behind the study is really that the addition of cabazitaxel hopefully will treat any PSMA negative cells, which may be invisible to the naked eye, not seen on the PET imaging, but also as a taxane will confer some radiosensitizing properties, which hopefully will enhance the radiation response from lutetium and overall with the combination lead to better responses for our patients. The study design is quite simple. It's just a single center, single arm study. And we're hoping to recruit about 40 patients over the next 2 years. Patients will be eligible if they have castration-resistant disease and have progressed on a prior androgen receptor inhibitor and docetaxel. And at least for the phase 1 portion of this study, they do have to meet specific PET parameters, as you can see. Just to keep it simple, we wanted to escalate only one of the doses of the medication. So we've kept the dose of lutetium PSMA fixed as per the dose used in the VISION trial. And we will be escalating the dose of cabazitaxel initially until we find the safe dose, at which point we'll expand further at that dose. The second trial is called the Alphabet trial, and this again is an early phase trial looking at the combination of radium-223 with lutetium PSMA INT. And this study came about when we looked at the longer term outcomes for patients who were treated with lutetium PSMA and found that the most common pattern of radiographic progression was actually bone marrow disease. So over 50% of patients develop osseous progression. And we theorize that this is due to micrometastatic disease in the bone marrow that's not adequately treated with the lutetium. And this comes down to the properties of lutetium itself as a beta emitter. And due to the path length and the linear energy transfer, or the, I guess, amount of energy in the radiation of lutetium, it's good for treating macro tumors where you get the benefit of crossfire radiation as well. But in micrometastatic disease, you don't necessarily get that. So the radiation may not be enough to result in cell death. So we thought if we can add a bone-specific radionuclide, which is radium, which is also an alpha emitter, so has different properties to lutetium, and therefore, hopefully with the combination will lead to better eradication of osseous disease, and therefore lead to deeper and more durable responses. The next study is the Violet trial, and this is not a combination trial. It's actually a novel radioligand of terbium PSMA INT. And this will be coordinated by Dr. James Buteau, who you met, one of our NUCMED physicians, who will be coordinating this as part of his PhD. And the rationale behind this study is that terbium compared to lutetium emits a type of radiation called Auger electrons in addition to beta radiation, whereas with lutetium it's primarily just beta radiation that's emitted. And the benefit of Auger electrons is that they have a much shorter path length or path range and a higher linear energy transfer. So hopefully this means that the treatment will be less toxic due to less bystander radiation, but will be more potent, and in particular will be much better at treating micrometastatic disease. So we're really excited about this study, planned to open in September this year. It is actually a true first in human trial. So for that reason, we will actually be escalating the dose of terbium PSMA initially. And we decided to follow a therapy style of dosing in terms of decreasing the dose with each cycle, corresponding with the presumed reduction in tumour volume. Yep. So the next study is POPSTAR-2, which is being led by Professor Shankar Siva here at Peter Mac. And this is a follow-on from the POPSTAR trial published in 2018. And it's really asking the question for patients with oligometastatic prostate cancer, is 2 cycles of lutetium PSMA INT plus SABR to all sites of disease, and patients are allowed to have up to 5 metastatic sites. Is that combination superior to just doing SABR to all metastatic sites alone? This is currently ethics approved as a phase 2 study, recruiting 92 patients, but it's actually being renegotiated as an even bigger and better study as a phase 3 trial. So it's still sort of finalising that, but I'm sure you'll hear more about this trial very soon. And finally, I just wanted to highlight the other trials that we have already open at Peter Mac evaluating lutetium PSMA. As you can see in the castration-resistant setting, we have a number of studies open with combination therapies. And in particular, we opened the Evolution trial this year, which is combining lutetium PSMA with ipilimumab and nivolumab. And this is building on the promising preliminary data that came from the PRINCE trial, combining lutetium PSMA with pembrolizumab. We do also have a trial in the hormone-sensitive space called Upfront PSMA, and that's led by Associate Professor Arun Azad, looking at whether 2 cycles of lutetium PSMA prior to upfront docetaxel is superior to docetaxel alone. And then moving even earlier in the disease setting, we also have the lutectomy study, which some of you may have heard about from Declan recently at the EAU conference, where he presented the preliminary data. And this is a study really looking at neoadjuvant lutetium PSMA prior to a radical prostatectomy. And without all of our wonderful sponsors and supporters, none of these trials would be possible at all. So we're very grateful. Thanks, Michael.
Thanks, Louise. That was a really nice overview. And as you've pointed out, thanks to all our our funding partners that really enable these trials to happen. So PCF, these are all investigator-initiated trials written by, clinicians, but without the industry support, they really wouldn't happen. And it's really a collaboration of philanthropy from US PCF together with some local matched funding from our Peter Mac Foundation, and then industry partners Novartis supplying PSMA 617 for many of these trials, and Bayer for the radium trial, Isotopia for the terbium trial. So many partners involved. So with that, we might start doing some questions and answers, and we'll try to elevate maybe some of you to the podium if you're able to. Otherwise, we'll just use our panel. There's a question from Carl Foreman. Now that lutetium Pluvicto is FDA approved in the USA, would it be the same dosage used in Australia and other countries? Ken, do you want to provide a German perspective on that?
So in Germany, we do use the same dose or the same activity as in the vision trial. And I expect the same to be happening in the US. I'm more curious to hear what's about in Australia, because in Australia, obviously, you have a lot of experience with different activities, starting with 8.5 gigabecquerel and going down.
Yeah, so our practice is to continue the therapy schedule at the moment. So we give 8.5 gigabecquerels for the first dose. We decrease by 0.5 down to 6 gigabecquerels for the last cycle. Look, the overall administered radiation over 6 cycles is identical. I think there's a minimal difference between these two. As this is commercialized, you're going to get a ready-to-inject syringe with 7.5 gigabecquerels. So I think that's a very practical approach. The real question maybe for the future is, can we increase the dose? 7.5 gigabecquerels seems extremely well tolerated. Could we double the dose and give 15 gigabecquerels?
I'm pretty sure that double the activity is safe. We have experience with other tracers. We have experience actually even with lutetium dotatate that up to 20 gigabecquerel can be safely administered. We had a discussion very recently at the Gordon Research Conference, even with representatives of Novartis, and there seems to be little room to really do such a study and show superiority of a high activity. But I'm absolutely sure that this is one of the things we can tackle in ANZUP or in a collaboration between ANZUP and US and European sites.
But
Another
Ken,
question.
can I ask?
Yeah, go
can
on,
I ask
Silke.
something not nuclear medicine? But why wouldn't you individualize those? Why would you just go escalate? Why wouldn't you think about trying to individualize the dose, because you can do all these beautiful dose symmetries that Michael has shown? Why don't you use them?
It's an excellent question. I mean, there are different pathways on how to do what you would call like a life cycle management, right? One of them would be exactly to go into like a personalized dosimetry is one thing. My feeling is that this would be there are even more roadblocks to move out of the way than just increasing the activity. The reason we believe we can increase activity is when you look overall how well it's tolerated and how large the therapeutic index is, that we are probably still underdosing, or we probably underdosing a lot of patients. Also seeing that only actually 46% of the patients in the vision trial showed a PSA response of decrease of greater than 50%. But this is another very important and possible way to move forward.
So we could take a bit of a radiation oncology perspective, where radiation oncologists do their planning and they decide exactly how much dose they want to give. And you can actually do this. It's a little bit tricky with gallium or fluorinated PSMA because it's not identical to the therapeutic because of the difference in half-life. You're imaging at 60 minutes. But there are some longer-lived isotopes, such as copper-64, where you can image at 1 day and then give exactly the same therapy. You can switch between copper-64 and copper-67, which Clarity is working on, and you could do very precise dosimetry. It would be quite labour-intensive. How practical is it to administer this globally? It may be that as this therapy evolves, you'll have some more boutique centres that really hyper-individualised dose. But I think for the majority, particularly to get this therapy available, which is what we want everywhere, we do need a standardised approach, because your community centre is really not capable of doing high-level dosimetry.
Yeah, I had to. I could see Silke laughing as you were saying that, Michael. But we might ask James Buteau a question about that, because using some of this sophisticated software like MIM that you have, we see you create these semi-automated dosimetry maps, but there's still quite a bit of manual overlay required to determine dosimetry. So, do you see a future where you could get what Silke wants, where on an individual patient basis you can calculate that dose after the first cycle and then calculate what the next dose should be in the following cycle? It sounds delicious, doesn't it, Silke? A really precision approach to say, this is what this patient's tumour is absorbing, therefore this is the activity we'll give next time around. How far away is that?
Yeah, definitely. I think there are two main answers to that question. The first one, obviously, we do have some biomarkers that can determine which patients will respond the best. Obviously, the highest uptake would do better on PSMA PET, and there's a lot of work also in quantitative SPECT, whereby especially between the first 2 doses, even the first 3, you can get a feel for who is going to be responding well or who is going to progress and won't actually respond to treatment. Often you do have the same correlation with PSA, but the images can give you a really good insight. And one of the main barriers is actually just getting, like you said, all of that contouring done, which for now can be manual. We did do some work with MIM, and so that we could reduce by 45% the time it takes to get that SUV mean, doing the whole body contouring, very reproducible with the manual method. And there are works all around the world. We have work in physics with Lockie and Price Jackson here, also working on some AI to get ideally that one-click solution and a fast response.
Fantastic.
Yeah, and I think there is an immense global effort by both academia and industry in deep learning of these images, and it's an area that's evolving very quickly. But I think the tools are coming, so I think it won't be long before at least you can get that SUV mean with a one-click solution, and hopefully get that in your community radiology practice. If that occurs, I think it'll pave the way for deep learning of our SPECT CT images as well. Another question was from Carl Foreman as well, was around combining lutetium with actinium as a possible treatment option. Does anyone want to comment on that?
Yeah, I think that's a really interesting combination. So actinium, just for everyone else who's not aware, is an alpha emitter. So I guess what makes that appealing is that alpha emitters have a higher linear energy transfer, so more likely to induce double-strand DNA breaks and lead to cell death with one hit, unlike beta radiation, which is more likely to induce single-strand DNA breaks. So it is a very interesting combination. I believe it's already in trial. I think, Michael, you had 2 trials on your slide combining actinium with a PSMA ligand, one of which I believe has opened at St. Vincent's in Australia and New South Wales. I think some of the challenges will be in terms of how easy it is to actually manufacture and distribute, but it's definitely, an interesting question and something we keenly await the long-term data from those trials from.
Ken, do you want to comment on this question?
There has been actually a very nice paper being shown at the SNMI just recently at Vancouver, doing like a tandem to 2 cycles of actinium, I think actinium J591 plus lutetium PSMA INT, and the curves look too good to be true. So I fully agree with Louise that this is a very interesting combination.
And what about other alpha emitters? Because obviously actinium-225 is not our only choice.
So obviously there's another one which is currently absolutely hot, which is obviously lead-212, also because it's going to be produced in generators. There's at least 3 or 4 different companies producing lead generators, which will make it widely available worldwide. So I think, yes, there are many other, but for example, there's also a terbium alpha version, but also the lead one.
Can you just explain what that
with lutetium.
Can you explain what that means as a generator for our perhaps non-nuclear medicine people on the call?
So the advantage is that more or less that you can order a generator which allows you to be eluted either once per day or a couple times per day. And this makes the whole logistics much easier because you have more or less the source of your radionuclide at site, and you depend less on accessibility from reactors. And this new version of generator is supposed to last for 2 years, which means you have to order one generator once every 2 years. which reduces obviously a lot the logistical challenges.
I think not only logistical challenges, but also radiopharmaceutical challenges. The super high energy of actinium means that the bonds can actually break between the actinium and the PSMA over time. So if you have to ship it overseas in transport, you're going to get some breakdown. Whereas with the generator approach, you are really cutting that down, making the production closer to the patient. Do you think that's relevant, or do you think that's not a particular issue?
No, it's absolutely relevant. This is absolutely a very important topic because as we have just recently experienced the shutdown of the Novartis production, we can see that this can happen every once in a while. If we have many local or regional productions, we are much less vulnerable to this. The second very important part is what also Silke asked before, is of course the costs. And I expect the cost of goods to be significantly lower for lead compared to, for example, actinium.
And I think a significant logistical challenge as you adopt this treatment in your centre is around supply, because you do need to order an individual dose for a patient. You can't have it sitting in your hospital pharmacy as you would for carbazitaxel or any other oncologic treatment. And it creates significant challenges because you need to order it perhaps 2 weeks before, and then 5 days before the patient may get sick and not be able to have the treatment, yet you've ordered a very expensive dose that's going to decay, and this can create some complicated logistics. How do you deal with that, Ken?
No, you're absolutely right. Also, the dream of personalized dosimetric activities is much more realistic in case when you have the production on site. No, you're absolutely right. For us, it's a challenge. Currently, as you know, in Germany, we still make around 70-80% of all the lutetium labeling ourselves. We only do currently Lutathera in label. And even there, we do have some challenges. It's absolutely true. On the other side, there's also some advantages, because right now, if a synthesis, local synthesis fails, the whole costs is on my account. Whereas if it's from the outside, then the risk is on the supplier. But it's a very complex situation. You're absolutely right.
We have a question on the benefit and effectiveness of Pluvicto in patients with BRCA2 mutations specifically. I wonder if our medical oncologists, maybe Louise, Kostos, are you able to say anything on particular effectiveness in patients with BRCA mutations?
Yeah, thanks, Michael. That's a really good question as well. So I think we know that there are some intrinsic tumour mechanisms of resistance, and some of those do include DDR aberrations, which confer a degree of radioresistance, but BRCA2 in particular, I believe, is associated more with radiosensitivity. So it does seem an appealing, target for patients with a BRCA2 mutation to have lutetium PSMA. We do have a trial at Peter Mac called the LUPARP trial, which is being coordinated by Professor Shanine Sandhu, and that's actually looking at the combination of lutetium PSMA with olaparib, a PARP inhibitor, for patients with and without DDR aberrations. So I think it will be really interesting when we see the long-term data from that trial and the breakdown of how patients specifically with a BRCA2 mutation do go. But at this stage, I'm not aware of any robust data that's available showing that these patients do, significantly better. Are you aware of anything, Silke?
I think Anthony Joshua, from Australia, he published, I think, some case series where there were exceptional responders in DNA repair defect patients. But I have also, before 2018, seen papers that have said these patients don't respond at all. So I think, Michael, you should go back to the therapy trial, look at the histologies and see, what's really happening.
Yeah, well, the great thing about...
I guess vision and your trial would be fantastic, because, you can look at, then you can see if there is a difference in the chemo arm, but especially interesting in the lutetium arm.
Yeah,
I believe actually. I was going to say, I think, Michael, that's already in the works, isn't it, to analyse the ctDNA samples from the therapy patients?
It is underway. I think, one of the great things about these cooperative group trials like the ANZUP therapy trial is that we do make an effort to collect translational specimens. So in the therapy trial, patients had blood taken at baseline, I think after 2 cycles and at time of progression, and they're all frozen. and they're now being sent to a variety of centres around the world for analysis. So we will have the answer to this. I mean, anecdotally, patients with BRCA mutations have an inability to repair DNA post radiation damage. They ought to be more radiosensitive, and perhaps we do see that, but by the same token, they also have more aggressive disease and a progressive metastatic phenotype. So I think the hope early on was that patients with BRCA or similar mutations of DNA repair would do better with radioligand therapy. Our evolving experience, however, is that they probably don't do better or worse than anyone else, but we don't have great data on that. However, combining olaparib, as in Dr. Sandhu's study, is of really high interest, and we hope to present the first results of that study early next year. And we've been talking about doing an expansion cohort to that study to enrich a BRCA2 cohort. Another question from an anonymous attendee. Sometimes we don't allow questions from anonymous attendees, do we, Declan? Okay. If I may ask, I am wondering why the therapy trial wasn't powered for overall survival as an endpoint, as it was an endpoint. So I think when we design these trials, we power for the primary endpoint, not the secondary endpoints. So we often have secondary endpoints where the study may be underpowered, but we want to analyse that and look at the answer. Rick Davis, what knowledge exists about lutetium-177 radionuclide reapplication on PSA failure, both from a safety, number of additional cycles, and time after first protocol? Who wants to answer that one? Ken, can we give more than 6 cycles?
I can give it a try. More than happy to. So we do have some data. Obviously you have a lot of people with personal experiences, right? So we are currently trying to actually collect all the data we have in Germany and pool it. It's all retrospective data, as you know. And actually we have now a total of 100 patients who have had more than 6 cycles. This includes both people who continued treatment after 6 cycles, as well as patients in the so-called retreatment group. And we are currently looking at both the toxicity, but also on the likelihood to benefit from this second round of PSMA religand therapy. We expect the results to be available around end of September.
Yeah, and similarly, we have been doing this for a while. So if you have a patient who has a great response after 6 cycles and then progresses, we certainly give a 7th cycle and an 8th cycle. There are quite a few patients where we have given up to 12 cycles. We have actually published some of that data in our first J&M publication, looking at our 50 patient outcomes where we had long-term follow-up. So we do think it is safe. I think this will pose a challenge in the US where it's not FDA approved beyond that. I think it could be used, but perhaps the insurance companies will shy away from reimbursing. But you do get some of these really exceptional responders. We have a number of patients who are 4 or 5 years after the first treatment, and they're not patients with indolent disease. They came into treatment with PSA doubling times of less than 2 months. So this is sort of the 5% of really exquisite responders, and we need to be able to offer more treatment to these patients because you can keep them alive for many years with more and more cycles of treatment.
So Michael, do you continue to treat after 6 cycles if the patients still have a significant PSA, or do you give them a pause and retreat them in case of PSA progression? In case of this, next question: how long would you want to wait at least until you retreat?
In the vast majority of patients, once we reach 6, we pause and we watch PSA, and we will wait for PSA rise until we retreat. But when that PSA rise is triggered, then we'll give more cycles. If that duration of response is very short, sometimes less than 3 months, then we will think very sharply what other treatment options are available. If the patient hasn't had, for example, carbazitaxel and the duration of response is short, we would not recommend further lutetium. We would say try something else. If they've got a BRCA mutation, try olaparib. If they've got high mutational burden or MSH mutation, go for immunotherapy. So we'll always consider what other treatment options are available. If they have no other treatment options left, we'll consider more lutetium. James, I think you wanted to make a comment.
Yes. Actually, there's a complementary question from another anonymous attendee. We can allow it? I
think we'll allow
it. So do you delay treatment with Lu-PSMA if there are no lesions detected by PSMA after 2 or 3 doses? And I think it asks the other question. So yes, giving additional doses, but it is quite useful also to pause when you do have these exceptional responses. We don't see anything on SPECT. PSA is shot down. We do see these exceptional responders that we can space out treatments by 6-9 months and then use those 6 doses over a much longer period of time and I think make the most of the treatment. It's a great question.
Yeah, so in the VISION trial, if you had post-therapy imaging was not done routinely, but even if you had a undetectable PSA, which doesn't occur very commonly, but it occurs in maybe that 5% of patients where you really achieve an undetectable PSA. Sometimes this can occur at cycle 3. So do you proceed with cycle 4 if you have an undetectable PSA? And our approach is to do post-therapy imaging in every patient. And if we see a outstanding PSA response, which is really a sort of 99% response or greater, combined with no uptake on the post-therapy scan, then I think we should think of this treatment as a radiation delivery device. And if you're not getting any radiation to tumour, then what are you achieving by giving one more dose? And we would pause treatment. And often in those patients, we find that the responses are quite durable. Sometimes, 6-9 months later, the PSA is still undetectable. This is really a small group of patients. And if you do the thought experiment, 9 months later, PSA is undetectable. What would have been the value from giving another cycle 9 months ago? I think it would be pretty low. So I think pausing is the right thing to do in that circumstance. You save a lot of money. You save the patient toxicity, renal toxicity, salivary toxicity, and you save that dose to reuse when the patient progresses.
Yeah, and I think that
go ahead.
Oh yeah,
I fully agree. I just want to reiterate one point. I'm a big fan of the imaging after every cycle as well. So I think this is really important.
Yep, definitely. And I think we actually do the SPECT imaging, so whole body SPECT. We don't do any planar, and it's pretty much like having a restaging every time. There is a question about the use other than dosimetry about the post-therapy imaging, and I'd say that's the other major use. We can actually have like a free PET essentially each time, and you can get a good idea how the patient is doing and adjust treatment based off that.
And as a personalised treatment, the patients really do appreciate seeing these scans after every cycle of treatment. They appreciate what's happening. With the art of PSMA theranostics, I think you also get a feel for how likely a durable response is, how likely a non-response is based on these imaging, and then you can start making alternative plans. If by cycle 2-3 you're already seeing new lesions forming on your post-therapy SPECT CT imaging, despite a reduction in PSA, you know that you're not going to have a durable response, and you can start asking questions of our medical oncology colleagues. What else can you offer these patients? Are there any other clinical trial options open? And get that set up ready for the patient.
5 minutes to go, Michael.
Can I maybe, sorry, Declan, can I be the devil's advocate here? First, I guess the approval is for 6 cycles. And that will be probably all over the world. So whatever you can do in Australia is fantastic. I love that personalized approach, but I think we have to be a bit careful because in other countries you will be kind of restricted by what is the approval. And the same thing is probably true for the re-challenge. That I know a lot of people do. We had also consensus that re-challenge, if all other treatment options are exhausted, should be done. But again, there is no approval for that, and I guess we have to be a bit careful. And then I want just not to break the enthusiasm, but there is patients. I've seen patients who are progressing in the liver and are PSMA negative. And I just would not rely on these SPECTs only, even if they look very nice. I have seen too many patients who were progressive with PSMA negative lesions. So I personally would never, ever do the monitoring only with PSMA-based imaging.
Yeah, I think you make some good points there, Silke.
And it's a practical matter. Not everyone can access PSMA after every cycle, every second cycle. Conventional imaging has an important role, doesn't it? Last couple of minutes, Michael, what else can we get through? Thank you all for your fantastic questions. We are trying to get through as many as possible. Michael,
shall we do one more question and then wrap it up?
Wrap it up, and Howard might want to say a few words.
Shall we start with we'll end with a controversial question. It has been asked by a few people, but John de Klerk from the Netherlands asks, discussion about lutetium PSMA INT versus 617. They produce it in their hospital for routine clinical use. with very good results, but some oncologists think it is not comparable to 617 in the VISION trial. What is the opinion? Ken, do you want to make a comment on that?
I think I'm going to lose a lot of friends right now when I say this, but the 617 and INT are not bioequivalent for me. They are very similar, but if you look at the dosimetry, you can see actually the dose, the kidney dose is significantly higher for INT compared to 617. And this reflects especially when we look at the current trial designs of the INT trials. Are they both efficacies? Absolutely, but they're not one-to-one bioequivalent.
Good point.
We might hand back to Howard for some last comments and perhaps to start the wrap-up. Howard, do you have any comments, or Andrea listening to this webinar today?
Just to say thank you to everybody. These interactive webinars are fabulous. Medical education is one of the pillars of our foundation, and I have to say Peter Mac and the ProsTIC team, Michael, Declan, Annette, it's just fantastic what you guys are doing to drive this field forward in a very educated way. So thank you very much. Thank you all the panelists that gave of your time, and the large number of people from how many countries, Michael?
We had registrants from 58 countries. Extraordinary.
58 countries. Phenomenal, the interest in this pharmacology and treatment. So thank you all.
Thank you, Howard. And also thanks, Andrea. Andrea, you've just published a manuscript in the last week. Do you want to just tell us about that briefly?
Oh, sure. Thank you, Michael. So each year we publish a meeting report on the talks from the PCF retreat. So the meeting report for the 2021 PCF retreat was just published in the ProsTIC, so check it out. And thanks.
Yeah, it's an excellent publication. It really goes through just such a wide range of topics, including quite a lot on PSMA theranostics. Declan.
Fantastic. Well, thanks very much, Michael. Thank you to our fantastic panelists, and thank you to all of you attendees for joining us today. We do hope you enjoyed this ProsTIC PCF webinar brought to you in conjunction with GUcast, our podcast. We will post out the links on Twitter as usual. You can find it through the ProsTIC channels, and you can also find it through GU_onc, which is the Peter Mac GU Oncology channels, or just search GUcast and you'll find it. And we'll be back, I suppose, sometime again soon. There's a bunch of interesting stuff coming, including lutectomy, which we recently presented at the EAU. We've had some questions about when we're going to talk a little bit more about this neoadjuvant approach of lutetium prior to prostatectomy. We're actually doing one this morning at Peter Mac on trial, and we will be back in a few months for sure to focus on the really early stage application of theranostics, which of course is still a research area, but an interesting research area, Michael.
And we might try to follow up a few of the questions, maybe on Twitter. We haven't been able to get to everyone's questions, but we do have them recorded here. So we might go to social media to try to answer a few of the outlying ones. Thanks, everyone, for joining today.
Thank you. Good morning, good night, good evening, wherever you are. I hope you have a nice day. Thank you so much.
Thank you.
Bye.